Good morning, I'm Dr. Deuk, and it is May 4th, 2023 at Deuk Spine Institute. We have our patient here visiting us from Ohio who has 4 discs that are causing back pain and left leg symptoms. So we're going to be fixing all 4 today. We'll try to do it through one incision. Lay still.
How you doing, my friend? You okay?
All right. Now, our patients that have surgery on their lumbar and thoracics are awake but sedated, meaning they're sleepy for the beginning of the surgery. When we get to the actual part where we do the surgery itself and go in and fix the disc, that's when we need them asleep. But for the very beginning, we need them awake, helping us. So, our first disc we're going to access is the L5-S1, the bottom disc. Lay still. Shot. You could see the L5-S1. Jordan, you want to show the audience the L5-S1? While I give some more numbing medicine. He's very sensitive. Thank you, Jordan. Did you see that, Henry?
Yes, we did.
All right. Shot. So that's the L5-S1 facet joint. We're sneaking around it. Let's get an AP. I think you're off on orbit. I'm not sure though. Maybe he just has short pedicles. So we're going to use a combination of front, back, and side X-ray images. Looks pretty good. You can see on his X-ray there, Henry, he has some curvature of the spine. We call that scoliosis. All right. I think we're going to be okay, Jordan. Let's see what you've got there. Yeah, that looks decent. I think we're okay with that. So our patients are, again, awake because I need their assistance while I'm placing some of these needles. These needles are going past structures like nerves, and I need to make sure that we are not too close to one of those nerves. The only way to know is for the patient to tell me. Shot. All right, just about there. So far looking good. L5-S1 disc, the one we're targeting first, is the hardest to achieve access to transforaminally. There aren't many spine surgeons in the world that do endoscopic spine surgery because it's an advanced technique that most spine surgeons don't know how to do. But the ones that do know how to do it, they don't know how to do L5-S1 this way. They do it translaminar, which is bad. That means they're going to be taking bones and ligaments out of the patient's spine. Is he comfortable? Reliable and comfortable?
Can you open your eyes? Yeah, good. We're going to ask you some questions, okay?
All right, you're doing great. Everything's okay. Just lay still. I could feel the first herniation with the tip of the needle. Okay. So far, everything's going well for him. For those of you who are interested, this entire surgery, we just did a surgery like this the other day. And just so you understand, watch the needle. There's 2 ways to fix this patient's back pain and leg pain. There's 2 that work. One is the surgery you're watching now, which is the best surgery in the world for this problem. It's done with a small, tiny Band-Aid incision. The alternative is what we did 2 days ago on Tuesday for a patient who had 4 discs, and his incision was this long, okay, in his back. And we had to peel all the muscles off his spine, and it's horribly painful surgery, even when done perfectly, the best way a human being can do it. And you know, these patients that have that surgery, they're in pain for literally months after a fusion. It's called the decompression and fusion surgery. So this is a far better surgery. You get back on your feet right away. Everything is done through this 7mm incision. I may have to do a slightly bigger, but I'm not going to do it yet because I have to get 4 needles through one little 7mm cut. And I don't know if I can do all 4. I'm going to try. I may have to make a second incision higher up, so let's see. All right, there's the second target, L4-5. Show it to us, please. Shot? That's correct. Now people ask me, Dr. Deuk-Majan, aren't you harming these discs when you go in there? The answer is no. And the reason is simple. I'll show you a video in a few moments explaining how the surgery works. But basically, we are entering the back of the disc on the side exactly where the tear is, so where the damage already exists. We're going right through that damaged part, and that's why we're not creating any new damage. Is he hiccuping or coughing?
How you doing, my friend? You okay? You okay? Yes. he's
Great.
okay.
Lay still. You're doing great. Don't move. All right. So far, perfect. Couldn't be better. I can feel the facet. By the way, I know I'm not explaining everything I'm feeling, but you can see the tip of the needle. And for those of you who don't know, surgeons, actually really good surgeons, get to feel everything with their fingers. I could feel the tip of the needle going through past the facet joint, past the ligament, and now I can feel it up against the herniation. Literally, barely touching it, I can feel the herniation. This is not something robotic surgery could ever do, just so you understand that. There's a lot of hype in the news right now about robotic surgery and AP. And robotics surgery and spine surgery, in my opinion, robotic spine surgery is relatively unnecessary if you have a good surgeon. Now, if the surgeon is not good, then the robotic system can help them plan and navigate the screw into the pedicle. Do you see that AP view, Henry?
Yes, we do.
All right, so you can see the tip of the needle is coming in from the left side. It's in the foramen. It's at the back of the disc. Show us where the pedicle mid-pedicular line is. Yeah, there's a pedicle there, and there's one down there, right? Lower, right there. So we are, I think that's it. So we are about to enter the disc at L4-5, all right? And again, we're low in the foramen, below the nerve roots. Let's go ahead and show our audience, why do people get so much back pain from a disc problem? How do discs cause so much pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. That video has shown you why do disc injuries actually cause back pain, and the answer is inflammation. So this patient has 4 discs that are damaged, all causing back pain and leg pain. We're about to enter the L3-4. And for comparison, I was talking about earlier in the week, we had a patient that had 4 discs operated on, but with fusion, the opposite surgery that should be done. And he wanted the fusion done. He didn't want the laser. And we had that surgery again on our YouTube videos. You can go back and watch it and see. But what a difference you're going to see between the two techniques. And once again, this is with 4 disc herniation. I think I've got it. I'm just trying to find the plane. There it is. Shot. All right, heading towards the final one. Shot. You're doing great. Hang in there. We're almost done. I promise. If I can get it all through one incision, I will. If I can't, we may have to make another small incision. I'm feeling like I might have to do that. Let's see. Because I'm hitting the transverse process. There we go. We got above it this time, and start moving to the inside shot. You can see the transverse process there. Shot. Shot. Is that it? Shot. You're doing great. Shot. That's aimed a little too high. So I may have to make a second incision. Shot. We're almost done, Shot. Almost done with accessing your disc. Yeah, it's too high. Shot. Give me an AP. Let's see where we are. So we've gotten 3 out of 4 discs accessed with the needle. We need one more, and then we're able to put him to sleep after we do our discogram. So we're too lateral. Let me try to get a little more medial. See if that helps. I'm going to try to get my needle a little bit more medial. That might help solve this problem. Let's see. Shot. Shot. That's the facet. AP, let's just see where we are. Any questions from the audience so far?
No current questions.
All right. Yeah, there's the TP. We're right on the top edge of the TP. You see that? So we might be able to sneak over, but if not, I'm gonna, let's see. There we go. Yeah, I just did. And it'd be nice if we don't have to make 2 incisions. Shot. That should be it. I feel the herniation. Shot. So let's get an AP. We're going to verify, and then Henry, I want you to save this, and we'll do an edited side-by-side comparison. Yeah, that's perfect. This surgery versus the open 4-level, 4 discs that we fixed on Tuesday. So I'm about to enter, and then we'll get that would be a good time point.
Copy that.
Shot. Yeah. Hold on. So this would be right here. Let's get some good lighting for Henry, because I want to have a nice comparison. So this is, 4 discs, 2, 3, 3, 4, 4, 5, 5, 1, same as we did on Tuesday, but instead of doing an open surgery, arthroscopically, through 1 7mm incision. Henry, I'll bring in the ruler, and then we're going to need our patient awake and ready to go. Can you see that, Henry?
Yes, we can.
It's about an 8 or 9mm incision versus, the fusion, which was much bigger. Okay. So our patient has back and left leg pain. How long has he had back pain for?
25 years.
Lower back pain for 25 years. That's sad. I can't even imagine having pain for 25 years. I'm so sorry you've suffered so long, my friend. How long has he had left leg pain?
I think about the same amount of time. Lower back and leg just got severe over the last year. Severe over the last year.
All right. So 25 years. for 1 year it's gotten bad. Now, when I asked him, where is your pain, he said, oh, it's in this area, you know, down here. Specifically on exam, he said it's in this area here. So pain was here. He has 4 damaged discs in this area. The L2-3, L3-4, L4-5. You ready to get this fixed? All right. All right, and he's got facet pain in his facet joints as well. We're not going to have you awake much longer. We're going to put you to sleep soon, okay?
You're doing great.
You're doing awesome. Any questions for me before we get started?
Said no questions.
All right, are you comfortable? All right. Anything you want me to tell your family or friends? Hmm?
I'm sorry?
That's fine. He said he's doing well. All right. All right. Any pain right now? So you guys can see right here, Henry, the lineup. L5-S1, L4-5, L3-4, L2-3, right? No pain? How bad is that on a scale of 1 to 10? 10? Is that where you typically get your back pain? So that's L5-S1, 10 over 10 concordant. All right, is it better? Is it better now?
Yes.
All right, so it went away. So folks, I just did a discogram. And Henry, can you see that the x-ray picture? You can see the dye leaking out the back of the disc through the tear. Yep. And then it's going down around the nerve roots and everything. So there's definitely an annular tear that's painful there. Are you better? No more pain, right? All right. How bad is that on a scale of 1 to 10? That's another 10 over 10. And is that where you get your back pain typically? Uh-huh. All right, good news. We're going to fix both of those permanently today. That's why you're here, right? Yep, we're going to get you fixed. Is the pain gone? So show us, Henry, the tear on the x-ray. Go to that x-ray view. And Jordan will show you the tear in the back wall, back of the disc. Posterior annular tear. That's where all the back pain comes from. All right, is that better? All right. How bad is that on a scale of 1 to 10? That's a 10. And look, the disc doesn't even look that bad. It looks cotton ballish, right? And that's where you typically get your back pain?
You said yes.
That is 10 out of 10. So we got 3 10 over 10 pains,
On the last one.
which is the most pain anybody can have. And it's all coming from places where he feels back pain every day, right? That's important. We want to make sure we're fixing where the patient has their pain every day. We call that concordant. Is the pain better? All right, so let's look at the last one real quick. Henry, let's go back to the x-ray at L3-4. You see the dye is mostly in the center of the disc. We call that a cotton ball, but it's not really a perfect cotton ball because you can see a tear at the top of the annulus running out to the periphery. That is a grade 3 annular tear, and that's where the pain's coming from. We're going to get in there, find it, and fix it. All right. Better now? All right. Sorry about that. How bad is that on a scale of 1 to 10? 10. So all 4 discs were 10 out of 10. So I was right. Now, we're going to put you to sleep, okay? And when you wake up, that pain will be gone for the rest of your life. Isn't that wonderful? All right. Give me a count from 1 to 100 out loud in Swedish. He's actually counting. I don't know if it's Swedish. I can't hear it. All right. Just count out loud from 1 to 100 in English then. If you make it to 100, I don't pay the anesthesiologist. He's skipping numbers like 20, 30, 40. All right. Well, he's going off to sleep for his surgery. We're going to show you a quick video on How is it that the Deuk laser disc repair, this tiny little, you see this cut right here, guys? This tiny little 7mm, 8mm cut. How can I fix all of his back pain with one tiny little cut? Keep counting.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back, and now you see how the Deuk laser disc repair through a tiny 7mm incision and tube is able to cure back pain. It's all about debridement of that inflamed annular tear. Is he just coughing or something?
No, I'm just moving around.
All right. Let me know if I can proceed.
Go ahead.
So we're aiming for the L5-S1 disc. We're doing a transforaminal approach. There are very few surgeons in the world that do this, like literally probably two, myself included, because getting through the L5-S1 foramen is very difficult for most doctors, most spine surgeons. They don't know how to do it. But if you're able to do it, what that means is you can avoid damaging the patient's spine, because the other endoscopic surgeons out there, they actually will take the lamina out and make a hole between the lamina. They call it interlaminar, and that hole is going to damage the spine. We don't want the spine being damaged. The whole point of the surgery is to go in and fix the damaged part of the spine without creating more damage. And unfortunately, invasive types of spine surgery like discectomy, laminectomy, fusion, all of those types of spine surgery, they're going to damage the spine while they're trying to fix it. All right. So I'm just trying to visualize his disc, and we're inside now. I can feel it. Take it out. We're inside the L5. I went through the tear very easily. It didn't take much effort. So he's got a very big annular tear at L5-S1. We're just underneath his L5 nerve root, and we're lateral to the S1 nerve root, for those of you who want to know. We'll take questions. If you're watching and you want to ask a question, type it up, and Henry will deliver the question to me, and I'll answer it for you, okay? How's he doing? All right. Shot? Can't really tell. It looks like we're in, right? Let's just find out.
Yes, sir.
Shot? Yeah, we should be in. And shot? We're in. Go ahead and take it out. We stream these surgeries live so that you, the viewer, can be right along with us, watching, asking questions, and learning. More importantly, learning. The way we train our surgeons today in the United States and around the world is they come into the operating room and they get to watch what the head surgeon is doing. And that's why I brought you along, so you can all be like surgeons in training, learning exactly what it is we do. You're watching it as it happens with high definition.
Can I go down with
As a matter of fact, your view of what's happening is better than actually in most surgeons' view, because I need the scope on. Come on. You guys got to have a checklist in your mind. Step by step, same thing every time. You need the scope on. Okay. All right, so the light is a little low. I would crank it up, maybe click it up 1 or 2 notches. Okay. Maybe 1 or 2 notches on the intensity. Now we're inside the L5-S1 disc. I'm going to try to remove the herniation. And remember, there's still a good part of this disc that's still viable. And we don't want to take the whole disc out. We just want to take out the part causing pain. So while I'm in here, I can look around and figure out where the pain's coming from. This is where his tear is. You can see the tear. You can see the scar tissue. Anything that turns a gold color is abnormal. You see the gold coloration? Those flecks of gold? That's all calcium. They're not quite bone spurs, but they are going to be eventually over time. It's called dystrophic calcification. And right now I'm zapping away the tissue that's causing his pain. It's all abnormal, inflammatory tissue and herniation. You can see the annular tear. It's right up against the end plate here, the L5 inferior end plate. This is where all of his pain is coming from at L5-S1. Now, part of the problem, folks, is that spine surgeons, they like to limit the surgery they're doing and keep it usually limited to fixing 1 disc per surgery. So that's one of the problems we have today in modern spine surgery, is that a lot of spine surgeons are not comfortable doing more than 1 disc at a time. And I don't mean endoscopically, I mean just treating in general more than 1 disc at a time. Okay? So a lot of spine surgeons will only treat 1 disc, and they will leave the other discs alone for another day. I'm just probing with my laser, feeling what that mass feels like. I think it's viable disc. How's he doing? All right. This is the lateral part of the herniation. Some of this is scarred up.
You have a couple of questions.
Yeah.
First one comes from Jordan on YouTube.
Hi, Jordan.
They asked, from my understanding, you clean up the annular tear, which is the cause of inflammation and pain. Is it still concerning that there is a degenerated disc that will never get back its height?
Yeah, great question. So Jordan, you're asking a wonderful question. We get that question quite often. Is it concerning that there's still a degenerative disc that will never get back its height? The answer is no, it's not. You see, in surgery and in medicine in general, our job is to treat disease or prevent disease. And disease is really quite interesting. It's not structural changes to the body, but it's structural changes that cause suffering or pain or loss of life, shortening of life, impairing the quality of life. So there really is a qualitative aspect to disease. Disease isn't a disease if it doesn't alter the quality of your life negatively, right? If you inherit $1 million you're changed physically. You have $1 million in your pocket, but that's not disease because it didn't make your quality of life worse, right? So disease is specifically has to impair your quality of life or shorten your life, okay, in some way. That's why it's disease. It has a implied negative effect on the person's health. So degenerative discs are not disease, okay? They call it degenerative disc disease when they actually cause pain and suffering. But the vast majority of degenerative discs out there cause no symptoms at all. As a matter of fact, every single human being alive over the age of 45 has degenerative disc disease, every one of them. They've done studies, MRIs on people, and they have shown, they've done MRIs on their spine on people who have no pain and no symptoms whatsoever. And they've shown that 90% plus have degenerated discs in their spine. So what that teaches us is that degenerative discs are not a disease, but when they cause symptoms, they can be a disease. It's called degenerative disc disease. So my goal with my patients and this surgery is to basically get rid of symptoms from structural abnormalities in the body. You don't need to go and do a fusion. I have that fuzz is back again. That fuzz is back. Just reach in like this and pinch and pinch and pinch, okay? Go in there and try to get it out. There you go. Somewhere right around where your fingers are. You feel it?
Feel it. Can I blow out your nose for a second? That's when I thought I saw it pop back up last time.
See, that's good. That should be good. Let's try that.
Sure.
Yeah, we must have moved it last time out of the way. All right, I'm back. Sorry. I have something in my mask that's tickling my face. Anyway, long story short, what I'm trying to say is if you don't like the way a degenerative disc looks, the only way to get rid of a degenerative disc is to cut it out completely and put a fusion metal in there, screws and rods. And I don't know anybody that thinks screws and rods and cages in their spine is better looking than degenerative disc. In other words, one structural abnormality is far worse than another. The metal and screws and rods looks even worse than a degenerative disc does. So if it's the appearance that bothers you, then you should be more concerned about artificial things put in your disc, like metal implants, artificial discs, cages, screws, rods, anything artificial put in your body should concern you more, because that's going to look less normal than an artificial disc, than a degenerated disc does. So the fact that you have a degenerative disc doesn't mean it's causing your symptoms. Lots of people have degenerative discs without symptoms. And my job here is to get rid of your symptoms so people can be normal and live a normal life, meaning they can do all the activities they want to do. They're not limited by pain coming from a disc. They're not limited by pinched nerves from a disc. Those are really the only two things that a disc does. They cause back pain when they're damaged, the degenerative disc, they cause back pain, or they cause leg pain, weakness, numbness, tingling. Call it radiculopathy, okay? So back or leg, that's it. Discs do nothing else for a patient. So we have lots of people with zero pain, totally normal life, running, jogging, biking, swimming. They do Ironman triathlons, and they've got completely degenerated discs. Why? Because the degenerated disc, the structural abnormality, is not the cause of their symptoms, because it's still there, and they have no symptoms. You understand? So this country, all these people, this world has been misled to believe that a collapsed disc, a degenerated disc, blah, 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 the arthritis of the disc is the problem, but it's not. It's actually this tear that I'm fixing right now. And we discovered this at Deuk Spine. We're the first to discover it in the world. We're the first to treat it, and the first to have basically 100% curing of back pain from these discs every single time. And again, it's back pain from the discs. Remember, there are over 30 causes of back pain. Discs are by far the most common cause. Injured discs, whether it's a herniated disc, bulging disc, degenerated disc, protruded disc, ruptured disc, extruded disc, whatever you want to call it, they're all the same. Discs are quite simple. They're basically a nucleus in the middle and an annulus around it. You saw in the video how they cause symptoms like back pain or leg symptoms. That's it. It's not complicated, folks. So you don't need to remove a degenerated disc. We don't need to fuse a degenerated disc. We don't need to put an artificial disc in a degenerated disc. We need to leave degenerated discs alone unless they're causing symptoms, in which case this is the best treatment in the world for a degenerated disc causing symptoms. So it has nothing to do with what it looks like on an MRI. It has everything to do with what it feels like to the patient. Symptoms and signs. Great question. Next question.
Next question comes from Jordan once more.
Almost done, by the way.
Jordan asks, following a procedure, do you do another MRI at any point in time to see if the tear has completely healed? How do you know that someone is ready to revert back to pre-injury levels? For example, jogging hard.
Yeah, great. I don't know what the last thing you said was. Something?
Like, for example, through that is jogging hard.
Jogging. Yeah, so great question again. How does any doctor that does surgery, which we've been doing for hundreds of years, how do they know the inside is healed? We know because that's part of our training, to know when tissues heal. You don't need a diagnostic imaging. If you have your gallbladder taken out, you don't get more tests done afterwards to see if your fascia healed, if the tissue's healed. We know they heal. Your body is built to heal. That's the good news. The only reason why I can't heal your annular tear is because the annular tear has this blue stuff stuck in it. It's called nucleus pulposus. So your body is not able to handle the nucleus pulposus. It cannot get rid of the nucleus pulposus. That's what we're doing here. We're getting rid of that nucleus that's herniated, and we're getting rid of the painful tissue in the annular tear. We know it heals. We don't have to get an MRI. An MRI will not show you whether your annulus is healed. MRIs are not that specific. They don't have that much resolution. Remember, you're looking at the inside of this tube from side to side is about 5.5 millimeters, okay? 5.5 millimeters. The MRI is not able to get more resolution than around 5 millimeters typically, okay? So MRIs don't tell you if an annulus is healed. The patient will tell you, and we know the annulus will heal, like all other tissues in the body. But there is no diagnostic imaging test that tells you that. The one thing I can tell you about the annulus and healing is that, well, there's a couple of things. Number one, it heals with collagen, okay, which is good. That's what it's made out of. So when a tissue heals with what it's made out of, that's always good. For example, if you have damage to your liver will not heal by making liver cells. It'll heal with scar tissue, okay? So if you tear your muscle won't heal with new muscle. It'll heal with scar tissue. The good news is your disc will heal with disc. So that's one thing I can tell you. The other thing I can tell you about discs, I'm almost done, another minute. The other thing I can tell you about discs and annular tears healing is that they take a very long time to heal. And I mean, we believe they take around 9 months to a year. So the only way to know for sure would be to go back in and put the scope in and look around, which would end up damaging the annulus. Just about done. 30 seconds or 20 seconds. This is the last of the herniation. Turned out that big mass was all scar tissue from herniation. Now we've gotten rid of it. So I think he's going to do fantastic. The L5-S1 disc is the one we're currently working on. We've got 3 more to go, and then we're going to treat his facet joints. He has facet joint pain as well at L4-5 and L5-S1. He wants the Deuk plasma rhizotomy. He's from Ohio. He does not want to come back here again. So we're trying to take care of everything in one shot for him. Now, for those of you watching and trying to study my technique, I'm really pulling hard to get this tube pointed more medial. To do that, I have to pull this tip of it where I'm working laterally. But you never want to pull the scope. You will break the scope, okay? The lenses inside the scope will pop out if you bend it. So you got to not pull on the scope, you got to pull on the tube. Otherwise, you're going to be spending $3,000 every time you bend the scope to get it repaired. They're very expensive to repair. All right, sorry. It's so strange, I'm not able to see more, you know what I mean? It's kind of dark. I think that's the light intensity.
Sarah, can you help with the light, please?
Just wondering if maybe we brought it up. Right now there's a little bit of blood in there. It is? You think that's a bulb or what?
Check that. No?
Yeah. That's the one. That's fine. We're good. I can see enough. All right, that should be it. Let's take a look. See if we can find the L5 nerve root. It should be right there. There it is. It's in that fat. We're inside the foramen. Let me just check the other side, Luis. Let me clean a little bit more here, laterally. Don't forget, if you're going to do endoscopic transforaminal spine surgery on discs, you've got to look laterally, which I did earlier, but there's still a little bit more here I need to remove. And by the way, as you start to take the herniation out of the tear, believe it or not, more herniation will start to reduce down, like start to drop down from other areas. It'll actually drop right into your field because you're basically creating a path of least resistance. So the additional herniation will kind of billow into your operative field so you can access it quite nicely. All right, there's the last of the tear right there. You see that? All clean, very nice, and all done at L5-S1. I'm happy with that. Okay, we're done here. We're going to next move to the L4-5 disc, which is the disc above. We're going to first use a little antiseptic to cleanse out the wound. We don't think the patient has any bacteria or anything in there, but we do this as part of our standard protocol for every patient. It's a standard surgical protocol, irrigation, wound irrigation. Everybody does that, at least they should. And we're cleaning it out with sterile saline.
Thank you.
Please do. Bring in the fluoro. All right. Great. So I'm going to pull this tube out, put a little pressure on the incision. And so far we've lost like 2 drops of blood, literally 2 drops of blood. So you need to lose 20 drops of blood to make 1 milliliter. 1 milliliter. Am I right, Dr. Berndes? I'm always quoting that. It's 20 drops per mil. Maybe blood's a little more viscous, so it may be 15 or 18 or something like that. But basically 20 drops makes a milliliter. Hold on. Hold on. Hold on. Did that needle come back? Let's see. Shot. Let me have the stylet. You got to be careful when you're taking that stylet out. You can actually pull the needle back. Shot. Uh-huh. Yeah, it came back a little bit, but we're okay. All right, take that. Yeah, the other one too, somehow. My God, they all moved back. How did that happen? Oh, the tube?
No, probably the pressure inside also.
Shot? Oh. Good thing we caught it. All right, we're just commenting on the needles kind of pulled back. We need to keep an eye on that. Don't want to lose our path, our safe path into the disc. Any other questions, Henry? Shot?
Yes. This next question comes from Trisha on YouTube.
Yep.
They asked,
What's the other needles?
do herniated discs always hurt to one side? Can they cause pain to the left and the right?
Hey, that's a great question. So they can cause pain. So it depends on where the tear is. If the tear is on the left, you're going to have more pain on the left, and you're going to have your left, say your left leg affected or your left arm. And if it's more to the right, you can have more the right arm affected and the right side of your spine affected. But a lot of people have tears in the middle that affect both sides, and a lot of people have tears on both sides. So we end up treating, for example, in the lower back, we're going to treat the side that the leg symptoms are on. And a lot of patients numb them. A lot of patients have, I'll do it, just leave it alone, okay. A lot of patients have bilateral symptoms, but say one disc L5-S1 may be left and L4-5 may be right, and vice versa. So it's really an art for me to figure out. I sit and spend a lot of time looking at MRIs. It's an art for me to figure out what discs are causing what symptoms on what side. And when we do our MRI review with people, I take all that into consideration. I look at the MRI, I see is a tear on the right, the left, more center, is it on both sides? And then where are the symptoms? So when I'm interviewing people, figuring out what to do to fix them, I'm always asking those kinds of questions. Take your time. So he needs a minute. So that's a great question. In the cervical spine, in the neck, I go in the middle and I can fix both sides, and I do every single time. In the lumbar spine and thoracic spine, I have to choose left or right. Lay still. You're doing great. So we're just going to make him a little sleepier. Just so you understand, I know a lot of people have questions about the anesthesia. Why is the patient moving around? There's two reasons they move around. Number one, reflex. If you're sleeping and I poke your leg, you're probably going to feel it and move your leg away. So it's reflex. You're not really aware of it. If I ask you the next day, do you remember anything? You'll say, no, I was asleep. So they're not really conscious and aware, but they're moving their bodies because they're responding to noxious stimulus, which is pain. The other option is that they're too light and they're a bit too aware and they're feeling it, so we want to put them deeper. And right now we're going to put this patient a little bit deeper.
That's okay,
We're good? All right. So we're right at the back of the L4-5 disc. We're going to enter with the dilator. Again, I use a hammer to get in. Shot. I could feel the tear. And I got to watch the tip of my guide wire because I don't want it going any further in. I'm going to pull it out now and give it to Luis. I'm going to then just tap on the dilator itself. And I'm going through that tear we saw earlier with the discogram. A lot of pressure in the disc. A lot of pressure. That means there's a lot of inflammation. Oh my gosh. And there is a lot. It's really hard to get this in. Now it's in. So there was a tremendous amount of pressure. What that means is, think about, oh, it's pushing it out. Hold on. What that means, folks, is that, let's get a shot. Imagine a swollen knee full of inflammation, right? Yeah, it's pushing it right out. Shot. So we're just going to have to be really careful. I keep hammering it in, and it keeps pushing it back out. What's pushing it out is the pressure inside the disc, okay? And that comes from inflammation. Shot. Good. So we're still in position. Shot. Shot. I think that looks pretty good right there. All right, let's take it out. Shot. That looks good. when you have a swollen joint, that's because of inflammation. That's the only explanation, and that is the crux of this condition. People have back pain from their disc because the discs are inflamed. And sometimes that inflammation spreads throughout the whole disc. And guess what? That causes degenerative disc disease. That eats up the disc over time. So by getting rid of this inflammation, I need the scope on, please. By getting rid of this patient's inflammation in their disc with this surgery, we're getting rid of their pain. But we're also getting rid of the thing that's destroying their disc, which is the inflammation and the annular tear, the herniation, okay? So understand, this treatment is not just about getting rid of back pain, but it's also about getting rid of inflammation, which is a destructive force of nature. All right, there's the laser. For those of you who don't know, that laser fiber is made out of glass. Glass is what's used to transmit light. How are we doing, guys?
Switching out, take that
God. Unbelievable. Louise.
Yes, sir.
Well, we need to understand why, but not right now. We can talk about it later. I want to understand why the masks for CPAP are not working.
We have another question.
We'll take it.
This comes from Jordan, once more, on YouTube.
Yep.
They ask, have you done this procedure on active athletes, and what is the expectation one should expect in the terms of performance level once the annular tear heals? Rather be realistic than optimistic.
Realistic rather than optimistic. Well, Jordan, you're bordering on offensive, just so you understand. I want you to understand something. Dr. Deuk was on the United States national soccer team. And I was the top soccer player in the United States back in the 80s, ranked #1. So, talk about professional athletes. I know all about professional athletes. Also, semi-pro windsurfer, and a really good swimmer, really good 440, 880 runner, sprinter. Not Olympic level by any means for those, but soccer definitely. Played sports my whole life. So no matter what professional athlete you're referring to, I've probably equaled or bested them with respect to activities. Of course, now I'm 53, I don't really play sports anymore. But trust me, I understand performance. So, realistic versus optimistic. Realistic is that, first of all, we've operated on many professional athletes, many. And if you actually watch our YouTube testimonials, which we have hundreds and hundreds of them, and you go through them and spend some time, you'll see many of them are professional athletes, hockey players, rugby players, basketball players, and they all get their pain cured with this procedure, all of them, and they all go back to playing sports. So what you should be asking is, what's the timeline to return to professional sports? And that depends on what sport you're playing and how many discs you have that need to be fixed, how successful the surgery is. So a realistic is 1 year, but many of the athletes can go back to their sports before 1 year. And 1 year is nothing when you look at how many people are on the no play list for professional teams because of back or neck injuries. They're sitting out their whole career. Look at Tiger Woods. Tiger Woods lost $1 billion or more worth of value because he didn't come to Duke Spine Institute. Instead, he went to shitty spine surgeons that were supposed to be the best, team surgeons, which, by the way, for those of you who don't know, team doctors, all of them out there, professional team doctors, all pay hundreds of thousands of dollars to the team to be the team doctor. That's how they get it. So when a team, professional team, football, basketball, whatever, is looking for a team doctor, they don't say, who's the best? They say, who has $100,000? You? You? Okay, 150. You're the one. Sign on up. So, the people that are team doctors, they pay to be the team doctors. They're not really the best. Got news for you. All right, there's the inflammation right there that we were talking about. Right in the crack. You see the tear? Tear is there and the inflammation is there. That's where the back pain comes from. That's what the Deuk laser disc repair fixes. So, since you're almost insulting me, I'll almost insult you. All right? And the almost insulting is, did you know that the team doctors all pay to be team doctors? They're actually not really good doctors. I bet you didn't know that. Everyone thinks team doctors are the best. Oh, there's a team surgeon for the Miami Dolphins. Blah, blah, blah. How do I know? Because I've been offered to be the team doctor, but I had to pay, just like everybody else. And that's a little secret they don't tell the public, so especially the athletes. But most athletes actually know. Their trainers tell them the truth. They don't actually go to the team doctors. Most pro athletes, when they get injured, they don't go to the team doctor because they know the team doctor paid to be there. And their trainers are the ones who refer them places. So trainers are not great yet at referring for back and neck pain because they're not sending a lot of people to us yet. But again, most people don't know about this surgery. That's why everyone's not coming here to get it done. Once people learn about the surgery and how it works and how it's minimally invasive, they're back to work, back to athletics, back to sports quickly, then they're going to be coming. There's no surgery in the world you can do for your back pain or neck pain better than this surgery. You tell me a surgery and I'll tell you why it's worse. I'll tell you why it's going to ruin your career as a pro athlete, okay? You may get a laminectomy, for example, horrible surgery. They're taking bones and ligament out of your spine. They're destabilizing your spine. You may feel better for 6 months, but then you're going to be back on the no playlist because your back's going to be hurting so bad. Laminectomy creates far more problems than it fixes. It's a very bad surgery. Destructive. Deuk laser disc repair, we don't destroy anything. The only thing we're destroying is a 7mm skin incision. And with laminectomy, that's about 10 times that size. So other types of spine surgery are far more damaging and destructive. Deuk laser disc repair is non-destructive. No narcotics are needed. The reason why people need painkillers after open back surgery is the surgery itself is destroying their body. When you destroy someone's body internally, they have pain. And that's why they need narcotic painkillers after open back surgery. With Deuk laser disc repair, we don't need narcotic painkillers. We don't prescribe them. People don't need them because we're not destroying the inside of your body. Okay? I don't know if that answered your question, but I would say to be safe, pro athletes should plan on taking 1 season off, 1 year off, and letting the disc heal. Any other questions?
Yes, this next question comes from Jordan once more on YouTube.
Jordan, you're on fire today.
He asked, I understand that a discogram is a diagnostic test to test. My understanding is that doctors have moved away from this test due to the damage it causes to the disc. Is that accurate? Just curious.
Yeah, great question, Jordan. No, it's not accurate. Discograms do not cause damage to the disc. That's false. There are doctors that believe that. You are correct. But they're wrong, you know. All I can tell you is that there were doctors that used to believe slavery was okay as well. Fortunately, we've changed our minds and we've moved on to a better place. But just because doctors believe things doesn't make them right. We use discograms all the time. We've been doing this surgery for 17 years with discogram. And the patients that get it done, they don't come back. Unless they've re-herniated, doing something they're not supposed to do. But that's only 1%. 1 in 100 will re-herniate. There's been no complications, surgical complications from this surgery. We've never had a nerve damage, spinal fluid leak, infection. Well, we're not putting hardware, so we're not going to get loose screws, right? You get loose screws with fusions. You get the implant failure with artificial discs. You get heterotopic ossification with artificial discs. You get adjacent segment disease with artificial discs. All those complications and bad things happen with invasive surgery. They don't happen with this surgery. We've never had a DVT. We've never had a heart attack. So it's very safe surgery. This is the safest spine surgery available. It has literally the safety profile is the highest. Yep, great question though.
We have a couple more questions.
We're just about done with this disc. I'll take the questions, that's fine. Let me just say we're almost done. You could see the epidural space with the veins right there at the top. That red stuff is not inflammatory tissue there. That's actually a blood vessel. So you got to learn the difference between the blood vessels versus the inflammatory tissue. The inflammatory tissue looks different. Blood vessels look like blood vessels. The blood is contained in the vessels. That's normal. We call that Batson's plexus. Batson's plexus. So normal veins that are found around the nerves and the spinal and the thecal sac within the lumbar spine. So, but you got to be able to distinguish between Batson's plexus and inflammatory tissue inside the annular tear. All right, we'll take the questions.
Next from Jordan on YouTube asked, sorry for the somewhat repetitive question on recovery, but can someone expect to lift weights following the year 1 mark? Nothing crazy, but somewhat decent weights, call it 40-pound dumbbells?
Yeah, Jordan, absolutely. Once your disc is healed, which we say a year, you can start lifting heavier weights. So just so you understand, I don't know what kind of surgery you're talking about, but let's pretend it's this surgery, the Deuk laser disc repair, and that it's lumbar for your lower back, okay? Let's pretend you're having the same surgery this guy's having. Then you can start lifting up to 40 pounds weights, but it's maximum 40 pounds for the first year. So you could do 20 and 20 dumbbells, or you can do a 40-pound dumbbell. But we don't want you lifting more than 40 pounds your first year, okay? After your year is over, you can go back to resuming normal weightlifting, normal. So lifting a 40-pound dumbbell is not a problem, or 2 40-pound dumbbells, not a problem. The reason why is that the disc heals very slowly. It heals slowly because there's no blood supply. Your disc doesn't have a good blood supply at all. So it's going to be very slow to heal. And as a matter of fact, the middle of your disc has 0 blood supply. The inner half of the annulus has 0 blood supply. It's only the outer half of the annulus that has a blood supply. So that's why the healing is so slow. But after a year, we believe the disc is healed enough. We don't see reherniations in our patients after a year. They don't come back with a reherniation after a year. They come back in the first 3 months with reherniations. And it's always because they don't do what we tell them to do. We tell them, don't lift heavy things. They go out and lift heavy things. And I say, why did you do that? And they say, well, I was feeling good. I thought I was healed. No, you're not healed. You're feeling good, but you're not healed. And so that's why I give my patients a back brace. I give them a wristband. I educate them. We put it in writing. We do everything we can to make people understand that disc is going to take time to heal properly. But once it's healed, you can do whatever you want. You can go play professional football, soccer. You can go Greco-Roman wrestling. You can do whatever you want after 1 year. All right, so what I'm doing is I'm using the endoscope and the grabber. We call it a pituitary rongeur. And I'm pulling out whatever pieces of herniated disc I can find left in this disc. And we're just about done. And then we're going to move on to the next disc. How's he doing? All right, good. It's a big surgery. 4 discs is a lot to fix. Most people, we were talking about this earlier, they have an average. The average number of painful discs we see is 2.5. So if we take all the surgeries that we've done, all the people we've seen and recommended surgery for, it's 2.5 is the number, the average number. That means the average person that has chronic back pain has 2.5 painful discs. Obviously, some people have 3, some people have 2, some people have 1, some people have 4, like this patient, but the average is 2.5. All right, the other questions you have?
His next question from YouTube, Jordan asked, what are some challenges associated with the L5-S1 bilateral procedure that you do?
Yeah. So what are some challenges from the L5-S1 procedure bilaterally? Great question. L5-S1 is the hardest disc to access transforaminal, which is the technique I use, going through the hole that's already there in your spine. It's a natural opening called the neural foramen. And the challenges are, you got an iliac crest, which is a bone that comes off your sacrum and rises up. And it comes into the area where we try to access the L5-S1. So it makes it a bit more challenging. Plus you got that L5-S1 facet joint, FACT joint, just outside of the foramen that you have to go past with a needle. And a lot of people have enlarged L5-S1 facets. So that makes it more difficult. But that said, I'm able to get 98% of the L5-S1 discs that I need to. I rarely ever have to abort an L5-S1. So the kind of things that would cause me to have to abort would be, for example, if the spine is very anterior in the body, very far forward. So it's hard to get to from the back, right? It's just really far forward. Or the facets are super, super big, or the disc is super collapsed. And again, I've gotten into many collapsed 5-1s, many big facet 5-1s, many anterior spine. The problem is when you have all of those things in combination, when you've got the really big facet, you've got the really anterior spine, you've got some listhesis where the spine is slipping forward, maybe a grade 1, and then you got a high iliac crest. That's when, and you got a fat patient who's really obese. That's when you are probably going to have trouble getting into 5. That's when I'm going to have trouble getting into 5-1. Other people will have trouble from the get-go, no matter what. That's why a lot of endoscopic surgeons, they don't know how to do 5-1. They leave it alone or they go translaminar, which is a bad option. I don't do that because translaminar is bad. It hurts your spine. They're cutting up your spine, basically, to get to the disc herniation. Great question. That's a good question, Jordan. All right, about 10 seconds left here. I've cleaned out the herniation, cleaned out the tear. It's looking really good. You can see the posterior longitudinal ligament, and this is just a little bit of, foraminal ligament there, but all the herniation is gone. I'm very happy. We're going to take a look, and then we're going to get out, and we're going to move on to the next disc. Little scar tissue right there from all the inflammation, years and years of inflammation. All right, what other question you got, Hen?
Next question from Jordan on YouTube once more. They asked, can you share a bit more about the laser you use? How does it differ from other places that advertise using lasers as a minimally invasive procedure that have been known not to work?
Yeah, great question, Jordan. Yeah, you're right. So it's not just about having a laser, right? It's not just about having a basketball, but it's what you do with a basketball. It's what you do with a football. It's what you do with a hockey stick and a hockey puck, isn't it? So anybody can pick up a basketball, anybody can pick up a soccer ball, you know, but there's only a few in the world that are the greats. They actually do amazing things with those tools, okay? With those balls or pucks or whatever it is. So you need to find a surgeon who knows how to use the laser, just like well, I'm just going to say it, the best basketball player of all time, Michael Jordan. All right, so what Michael Jordan could do with the ball, not everybody could do with the ball. So you've got to find a surgeon who's good with the laser, who knows what they're doing. The vast majority of laser spine surgeons, they don't actually use the laser. They just say laser because they want your business. You come there and then they put you to sleep. You have no idea what they did. But they didn't use the laser. And more importantly, they all drill holes in your spine. You don't want holes drilled in your spine. We're not making holes in people's spines here. We're going through a natural hole. The point I'm trying to make is the surgery you're watching me do today is incredibly difficult to do. And I make it look easy because I'm talking to you while I'm doing it. And I've done so many. I'm really damn good at it. But 99.999% of spine surgeons can't do what I'm doing right now. So they don't want to lose the business, so they just advertise laser spine surgery. You, the patient, have no idea what they're doing in the operating room. But here, you see, you're watching me operate. You see this? You, marking pen, can you see this here, Henry?
Yes, we can.
Jordan. Is that how you spell Jordan's name?
Yep.
Jordan, you're watching me operate live. So guess what? I can't lie to you guys about the laser or hide it from you. You're watching me use it. That's one of the reasons we do live spine surgery, is so people can see the truth. We're not full of shit like all these other spine doctors are. We actually use the laser and we actually cure back pain. That's why our patients do testimonials. As a matter of fact, we have so many patients that we cure, we can't even keep up with all the testimonials, right, Henry?
Correct.
It's just not possible because we don't have all the resources to make every single patient a testimonial. So, all right, damn it, somehow these came out again. All right, we need to look before we take it out. Let's get in here with the fluoro. Because I haven't even taken the tube out. So the tube could not be the reason. These discs are under so much pressure, they're pushing the needles out, which I've never seen that done before. Just so you know, this is a first in 17 years and 1,600 of these surgeries. Fucking, look at that. It pushed the damn needle out. That's incredible. Oh. Shot. Damn. Great. It's hitting the back of the bone. That sucks. All right, well, I'm going to leave it there for now. I'm going to take this out. Hold these here down. Don't let them come up. Hold them down. All right, so I'm going to try to reposition that L2-3 needle because it came out from the pressure, just pushing it out. Shot? Shot? So we also show our surgeries live because we want people to see that, yeah, when we do have a problem, challenge, we actually deal with it like we're trying to do right now. And you get to see how we deal with it. So there's a learning opportunity. So it's not just the same surgery over and over again. There's actually, yeah, definitely I could see the needles are getting pushed out because of the inflammation pressure within the disc. Again, never seen that before. I've seen other tools get pushed out. I've never seen the needles get pushed out. Shot? Shot? Yeah, fucking thing. All right. Let me have the guide wire. Damn it. Shot. So we're literally right above the disc against the end plate. I'm just going to treat this one now because this is going to continue to be a problem. So I have to address it now before it gets worse. I'm just going to treat this one now. Shot. 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 All right, so that's looking better there. Shot. I'm going to take this out so I can redirect the tip. Shot. That's better. See that? That's what we want. Shot. All right, that's better. All right. Anyway, I had to skip the 3-4 to deal with the 2-3 disc because our needles were getting pushed out by inflammatory pressure going on inside the disc. Shot. Let's make sure the dilator's not moving back. It did. A little bit more. Go. Shot. Let's try to get this in. I'm going to need lots of shots, Jordan. Shot. There we go. Shot. That's better. So, shot. All right, we're inside the disc. We'll take the dilator out. Shot. That looks good. Let's get fluoro out. Let's get the show on the road. So we're going to come back to the other one, L3-4, and do it later.
Scrub on, please.
So far, his surgery is going very well. I'm very encouraged by the fact that he had 10/10 pain at each disc I tested with the discogram. And Henry, there's the tear, by the way. Let's show the audience, Laser. Let's show the audience how the Deuk laser disc repair works once again.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Laser. All right, welcome back. Now you've had a chance to see what the Deuk laser disc repair, actually how it works by, it's called the debridement of the annular tear. We got a little something on the scope. I'm going to clean it. It may be between the scope and the camera, so let's see. That's better. Little schmutz is gone. So we were talking about laser earlier. One of our viewers said, hey, what's the difference between your laser and everybody else's? The difference is I actually use the laser. They don't. They're not going to show you their surgeries because they don't use the laser. They just advertise it. As a matter of fact, there's a company in London right now we're dealing with called the London Spine Institute. And they've basically stolen the Deuk laser disc repair, and they're telling everybody they perform it there, but they don't. And they have it on their website, Deuk laser disc repair, we perform it here. And then when patients go there, they tell them, oh, we don't actually do exactly that. We do something like it. So that's basically false advertising. Okay, we can't control what other doctors do. Okay, we can't control what other companies do. But I can tell you they're all fraudsters, all of them. And I'm not making that up. And you either understand that or you don't. They're just fraudsters. If they did what we did, then they would be curing people. They'd be putting all their results online. They've got far more resources than we do. We're a tiny company here in Florida, 20,000 square foot building, 70 employees, 1 surgery center, 3 operating rooms, 5 doctors, that's it. And these other companies are far bigger than us. They cannot do what we do. They never can, they never could, and they probably never will. All right, so that doesn't keep them though from lying to the public and telling people they can. Ask them for proof. We put our proof right in front of you. You can see it. I use this laser that you're watching every single surgery, 100%. And I use it the whole surgery. So this is clearly laser spine surgery. I'm operating on the spine. I'm using this laser. I use it every single surgery. We show you every single surgery from beginning to end. So if they're doing laser spine surgery, have them show you. There was a company in the United States called Laser Spine Institute. They were over in Tampa. They actually expanded to Ohio and a few other places. Anyway, they were super wealthy, but they were super dishonest, okay? And they said that they did laser spine surgery, but they never really did. I had neurosurgeon friends that went to work there, and they went and did surgery over there, and they never used the laser. The laser, they said, sat in the corner of the operating room and was never used. They just use it for marketing to get people to go there. That's like saying we've got the fountain of youth, and then you go there and there's no fountain of youth. Instead, they have some liquid for you to drink, like called Red Bull, and they've got some cream to put on your face, but there's no fountain of youth. So it's false advertising. There's lots of false advertising going on out there when it comes to spine surgery, specifically laser surgery. But we are the only true laser surgery spine center in the world, Deuk Spine Institute. And we show you the laser. I know all these other spine surgeons. I know who they are. I know what they do, what they don't do. Okay? And they don't do what we do. Part of the reason is they don't know how to, and they probably never will unless I train them. What we do is hard. It looks easy to you because you guys watch the surgeries, and I do it the same way every time. All right? But it's hard to do it just right. And, you know, like those shows you watch where they're showing you how to make a really good dish that tastes good, but they leave out key ingredients and stuff. You know, they do it intentionally so you can't really copy what they're doing. We're not doing that. I'm showing you everything. But the truth is, with what we have available to show you, which is our live stream video system, I can't show you everything because it's 2-dimensional. And the real human being is 3-dimensional. So there's a 3-dimensionality aspect to this, you know, whole surgery that you're not getting because you guys are looking at a 2-dimensional monitor. Whereas I'm actually feeling things too. You guys can't feel what I feel. I literally can feel with my fingertips the different tissues. I can feel scar tissue. I can feel the annular tear. So you guys are being deprived of that information, which you really do need in order to really appreciate exactly how the surgery is done. What I'm saying to you is, doesn't matter how many people watch how many of my surgeries, they're never going to get the feel of the surgery. And the feel is very important. Feel is very important. So as much as I wish I could share my feelings with you, which I am, I can't share all my feelings with you. Therefore, you, the viewer, observer, is never going to get the full experience. So anyway, done here.
Lights on, please. Thank you.
That was an easier one, but we got it cleaned out. There just wasn't quite as much degenerated disc there, which is good for the patient. Less degenerated disc, faster recovery, better recovery. So. All right. Great questions from the audience today. I appreciate all of your interactions. We've got one more disc, and then we're going to fix 2 facet joints. Remember, the number 1 cause of back pain, the disc. The number 2 cause of back pain, the facet joint. The number 3 cause of back pain is the sacroiliac joints. The number 4 cause of back pain is the piriformis muscle. And piriformis muscle and sacroiliac joints are pretty darn close. But they're very small numbers compared to the disc. The disc is, in my estimation, around 80%, maybe 85% of back pain. And that's why we do so many Deuk laser disc repairs, because there are so many people with back pain coming from the disc. One thing you'll appreciate about the surgery compared to the actual fusion surgery is there's no bleeding. And because there's no bleeding, there's no muscle damage, and there's no scar tissue. All right, so this, watch out. I want to show Henry where we are right now. Henry, you see this?
Yes, we do.
Tiny 7mm cut. So this is for that comparison between the fusion that we're going to do.
Copy that. Also, we have a question.
Yep, we'll take the question.
This comes from Moises on YouTube.
Moises,
Yes.
welcome to our live stream. Thanks for asking.
They asked, will this work for a 7.3 millimeter herniated disc at L4, L5, and what is the cost? And also, can you recommend someone in Texas?
Yeah, Moises, great. So number 1, yes, this surgery, the Deuk laser disc repair, works. Let go. For a 7.3 millimeter disc herniation at L4-5. Second of all, there is nobody in Texas that does this. This is only done here in Florida at Deuk Spine Institute. You're going to have to travel, my friend. It's just like me if I want to go see a Formula One race in Austin, I got to travel to Austin, Texas. Okay? If you want to see the Eiffel Tower, you got to travel to Paris. If you want endoscopic laser spine surgery that works, you got to come to Florida. That's where it's at, my friend. Sorry, nobody in Texas does this. You guys have the Texas Back Institute, but they're all about artificial discs and fusions. Okay, so they're already 20 years behind the technology. I say that because the first endoscopic spine surgeries were really done around 20 years ago, and they were done by a small group of really top spine surgeons in the world. In Germany, Korea, the United States, there was one, Dr. Anthony Young, over in Arizona, and he's been doing these types of surgeries on the lower back for 20 years. He's a pioneer. I talked to him the other day. He's one of my mentors that taught me the endoscopic technique. And he doesn't use a laser, he uses a radio frequency probe, which is, in my opinion, not as good at all. But, you know, he made good money selling radio frequency probes, so that's why he promoted it. I didn't see the radio frequency probe as the best treatment for my patients. I saw the laser was much better. That's why I went with laser. So he did similar surgery, but without the annular debridement, and he used the radio frequency probe. I used the laser, but he still taught me a lot, and I respect him, and he's a true pioneer in the spine surgery world. But the Texas Back Institute, on the other hand, shame on them. They are making lots of money, not just doing your surgeries with artificial disc infusion, but their top surgeons get kickbacks from the implant companies. They are on the take. I know them all, Scott Blumenthal. I know a lot of those guys at Texas Back. Some of them are retired, Richard Guyer, but they are the ones who basically were getting a lot of money paid to them from the companies that manufacture screws, rods, cages, and artificial discs. And I think a lot of their surgeons are still on the take. Now, are these legal? Who knows? I'm not going to say they're illegal, but certainly it's unethical, in my opinion, for spine surgeons to be compensated for putting in implants into patients, besides what they're supposed to get paid for their professional fees. And maybe making money off the facility fee, that's fine. But to be paid by the companies to promote the use of these metal implants when there's less invasive surgery, like endoscopic surgeries, that's been around for 20 years, that's not right. See, I changed the way I treat my patients because I know this stuff works. And it works without putting metal in people. But metal makes a lot of money. A metal surgery like this would make a hospital and the surgeon $500,000, $500,000. That's what a surgery like this done open would cost, 500 grand, okay? And that's money split between the surgeon, the implant company, the hospital, the nursing staff, the anesthesiologist, pretty much all in. $500,000 for a 4-level decompression, reconstruction, instrument infusion with interbody cages, posterior instrumentation, etc. So $500,000 surgery, we turned it into a, I don't know, maybe a $50,000 surgery, so 10 times less. That's better, and it's better for the patient because they're going to be, this is outpatient surgery, folks. I don't know if you guys realize that. I didn't mention that earlier, but this patient's going to go home an hour after their surgery. So we're going to be done in about 15, 20 minutes, and the patient will go from here, what is that, to the recovery room, and then from the recovery room, he's going home. He's going to go home today, and he's going to be up walking around today on the beach here in Florida, because we're right near SpaceX. Maybe he'll go over and watch, look at the SpaceX rocket. 3 o'clock in the morning, they were launched one? Wow, just this morning. And the point is that this surgery is much better for patients. And yet, shame on spine surgeons for insisting on putting metal in people, okay, because of financial gain. But that's the problem we're dealing with today. That's one of the reasons we broadcast, so people can see you don't need metal in your body, in your spine to fix your back pain or neck pain. Okay? All right, what other questions do you have? I don't know if there's a connection issue with the light.
Next question comes from Jordan once more on YouTube, and they asked, is intradiscal PRP/stem cell to repair an annular tear a joke? Seems like it might have a similar value prop to what you do in terms of healing an annular tear, but seems like it could be a scam.
Oh yeah, yeah, absolutely, great question. So the question is from Jordan once again, great question. Hey doc, this whole idea of injecting PRP and stem cells into a disc, it sounds great. What do you think? Well, yes, it sounds great, but it doesn't work. Okay, it just doesn't work because they're not actually doing a debridement, and they're just injecting them in the disc. We've tried it. It doesn't work. It actually makes people worse, a lot worse. So we stopped doing it. We don't even offer it anymore. And we perform stem cell treatments at Deuk Spine all the time. Stem cell, PRP, we've been doing it for years. Like everybody, we do joints. It works for big joints, knees, hips, shoulders usually. It can give you a long-term good relief. However, when you inject it into the disc or the facet joints, it doesn't work. So if you want to waste your money doing the stem cells and PRP on your disc, go for it. Just remember our phone number and give us a call when it fails to work. One of the things we try to do at Deuk Spine for people is we try to educate them on what not to do. Every one of those treatments you guys think about, talk about, have heard about, we can do here. We're not limited in any way. The most spine surgeons and facilities are limited by the cost of equipment, the cost of the implants, the cost of whatever, you know, the supplies. We have zero limitation. We can do any spine surgery in the world. Many of them are limited because the surgeries are too invasive and they can't do them. We do the most invasive surgeries here at Deuk Spine. Our first surgery we ever did here was taking a tumor out of somebody's spine. Okay? And that's one of the hardest surgeries there is to do. So all these degenerative surgeries, no problem. Fusions, laminectomy, microdiscectomy, artificial disc, osteotomy, whatever. We've done it. Including endoscopic surgery, PRP, stem cells. The point is, even spinal cord stimulators we've done. We don't do them because they don't work. That's why. We actually don't do procedures because we know they're not going to work. Other doctors do procedures because they make money. They know they're not going to work too, but they want to make the money. That's one of the differences with our company is we're not going to do something that doesn't work. Even if we're going to make money, which we always are going to make money on procedures that we do, but we don't believe in doing things to people that don't work. It's an ethical decision. You're not going to find that with other doctors. Other doctors, see, they don't, it doesn't bother their conscience because they believe that's all that's available. So why not? You know? Hey, I'm going to do this treatment for you that doesn't work, but nothing else works, so you might as well do it and make money. That's their mentality. That's not ours. See, the difference is we actually know what works and what doesn't. And because we have something that actually cures pain, it's hard for us, it's impossible for me to recommend a treatment that won't cure the pain, like disc seal or barricade or stem cell or PRP or interceptor device or mild procedure. I mean, I could go on for hours. That's how many different procedures there are available. Epidurals, none of them fix the problem except for this surgery you're watching right here, and fusion. Fusion will also fix the problem, but why put somebody through a fusion? You see what I'm saying? It's unnecessary, it's dangerous, it's invasive, it's painful, it exposes them to narcotic use they don't need. There's too many negatives. It takes out bone, ligaments, destroys muscle, causes scar tissue bleeding, potential for infection, hardware failure, adjacent segment disease, loosening, pseudoarthrosis, CSF leak, pseudomeningocele, pneumonia, DVT, pulmonary embolism, wound complications. I mean, the list goes on. All those are problems associated with invasive back surgery that we don't need to do here at Deuk Spine.
You have about 5 minutes.
Five minutes for the disc. And then we're going to move on to the, look at all this damaged disc in here, by the way. All the blue stuff is damaged nucleus pulposus, degenerated, staining blue. Normal nucleus stains, it doesn't stain, it's white. So only degenerated nucleus stains blue. And it's a lot more at this disc than the other disc. So this disc is particularly bad. But we'll get it cleaned up. Henry?
Yes, sir.
All right. So we answered one question about the stem cells and PRP. And I'm wondering, are there any other questions?
No current questions, but we do have a comment from Moises on YouTube saying, "May God continue to use you, sir, and thank you for answering my questions."
Moises, you are welcome anytime, any place. I do answer a lot of questions after surgery on the YouTube videos. Some people like to write a question on the YouTube video, and I'll answer those usually. So if you do come up with a question later, feel free to find that YouTube video and just type in the question in the comments, and I'll usually be able to find that and answer it for you. Okay, so you guys see a little bit of pinkness right there. That's the outside of the tear. And that pinkness is inflammation. We're getting zapping it away. That's where all the pain's coming from. And it's been coming from what we've been removing as well. But this is on the superficial disc where the tear is at the surface of the disc. That's where the worst pain is always going to be because of the number of nerve fibers, pain fibers in that area. at the surface is much higher than deeper inside. All right, about probably 3 more minutes, 4 more minutes, and we'll be done. Oh, there's the end of the tear. You guys see the epidural space up there? 12 o'clock, just above the laser. You can see the end plates coming together at the back of the disc right here.
Yes, we see it, and we have another question.
Yeah, I just want to say, see at Deuk Spine with the Deuk laser disc repair, we really do use the laser. I mean, have you seen me not use the laser once? Every single disc has been repaired with the laser. That's because, no joke, the laser truly is the best tool for this application. There's nothing that comes close. Nothing. This is the fastest, safest, most precise tool available in the world, available today, that will fix this problem right here that I'm working on. If I use metal stuff, like scalpels and stuff, it won't work. They won't take it out. It just slips out of them. It slips away from them. And you would be damaging the patient's body even more by using scalpels that don't work. So, people say to me, why do you need a laser? Why do you need a laser? This is why. Look how effective it is at cleaning up this tear. There's nothing in the world that even comes close. So we don't use gimmicks at Deuk Spine. We just tell you the truth. May hurt your feelings. That's okay. Not here to butter you up. I'm here to teach you something if you want to learn. And I can teach you. By the way, it's interesting. At this disc right here, you got the end plate right there of L4. Right there, underneath that white stuff right there, that's all the bony end plate. You see how this tear on this particular disc is like right along the end plate? That's the end plate. And it's at the bottom of the disc rather than the top or the middle. So the tears that we see are often middle, top, or bottom, but everybody's different. Okay, everybody's different. Just want to get a little bit of this, and we should be done. And then we'll move on to our DPR, Deuk plasma rhizotomy. So earlier we were talking about veins. You can see a vein right there. You guys see that? That little bleb right there, that's a vein. That's blood moving through a channel called a vein. Look at that. You see that with the heart pumping? You can actually see the, oh, there, I just pushed it out. Now it's filling again. Look at that. That's with the heart pumping. That's pretty cool, huh? And then you got some fat cells right there. Each of those little, like diamonds, is an individual fat cell. Okay, so we're done.
Lights on, please.
Very cool stuff. We're done with the laser part. We fixed 4 discs. Scope off. All right. So check this out. Henry, for your comparison, obviously. What a difference, huh? Big incision on Tuesday. All that muscle being pulled off the spine with the bovie and the cob for a fusion compared to this tiny little cut. This is why I do endoscopic Deuk laser disc repair. I don't do fusions anymore. If you could see what I was talking about. We can't really show you because then YouTube's going to age restrict our video. That's what they do if you show too much meat and potatoes. We always have some people that probably complain. Dr. Deuk, surgery is gross. It needs to be age restricted. So, give me a second. Stay out. I'm going to show you guys. I just want to apply pressure for a moment, and then we're going to show you the incision. Can you see pretty well, Henry?
Yes, we can.
All right. So there's really no hematoma. The muscle's soft, and the whole surgery is done through 4 discs, folks. 4. This would take most surgeons multiple surgeries over a lifetime of pain and suffering. We did it in, what, an hour? Hour and a half? All right, all done. Let's bring the fluoro in. Now we're going to fix the facet joints. He's got facet joint pain as well as disc pain. I picked up on it on examination. He's actually got more than just 2 facet joint pain on the left. He's got piriformis pain, sacroiliac joint pain, trochanteric bursa, trochanteric bursitis, and iliotibial band pain. So what happens is he injured his discs and his facets Then he started walking around and limping and having bad posture because he's trying to like unload the disc herniation and leaning to the side. That's what people do, right? When they have a back pain, they kind of lean to the side. And then that causes other areas to have problems. And that's why we encourage people, if you've got back pain, come get it fixed now before you start developing other secondary pain causes like trochanteric bursitis, facet syndrome, iliotibial band, sacroiliitis like this patient. Okay, so we're going to be on the left at 4-5-S1. You can see the pedicle of 4 right there. And I'm going to go down to that pedicle. We're going to then, right where the transverse process meets that, oh, it's too high. We're going to go to where the transverse process meets, there it is, with the, show us the pedicle. Show us our target. So there's the pedicle, it's circular. Show us the target. It's right where the arrow is. You guys see that? Show us the transverse process. There it is. It looks like a finger sticking out. You want to follow the top border, top, follow it medially, right where it joins with the circle of the pedicle, right there. That is the perfect spot. That's where the nerve is that basically is responsible for pain at the facet joint. So a little bit low. So if I can nail that nerve, shot, if I can burn it, it's right where the tip is there. If I can burn that pain nerve, it's called the medial branch of the dorsal ramus. Shot. It's called the medial branch of the dorsal ramus. If I can, it's right there. Shot. Oh, it's perfect. If I can get that spot and burn that nerve, then I'll take his facet joint pain away. It's called a rhizotomy. And I'm not the first person to do it. Whenever you're ready. Lots of doctors have done rhizotomies before me, but I'm the first person to come up with a new way to do it, and we call it the Deuk plasma rhizotomy. And the difference is I'm able to kill that pain nerve permanently, whereas other doctors, pain management doctors, they do it temporarily. Now, why do they do it temporarily? Because they don't know any better, number one, probably. But number two, if you're a pain management doctor, I mean, from a financial standpoint, do you want your patient's pain gone? Think about it. Pain management doctors, they don't get rid of your pain, they manage your pain. So every time you come back, they're making money. They're not really interested in fixing you. They're more interested in you coming back over and over again so they can keep making money off you like an annuity. And that's the sad truth. And I realized that early in my career, and I realized pain management docs really aren't helping the situation. Sorry, but it's the truth. They're just perpetrating the situation. They're basically giving patients enough temporary relief to have them keep coming back. By the way, I'm struggling a little bit here because I'm on what's called the mammillary process, which is on the top of the transverse process, right where it touches the superior articular process, and his is pointy. So I'm actually it's shoving my tip to the side and making it move. I just have to be super careful, make sure we stay in the right place. And it's nothing, Dr. Burnett, nothing you're doing at all, but don't worry about it. I'm just keep sliding off. There, if I can just stay on. It's a little too low, right there. It's like trying to sit on the top of a pointed roof with your tool, and it's not easy to do. I feel the superior articular process medial, which you want to feel. And you have to be good at visualizing these things in your mind's eye. You have to see them. It actually is good if you have some experience doing these kind of open surgeries. I've had thousands of these patients. Open back surgery where I've seen these transverse processes, seen the superior facet. I know exactly what they look like. And what I do is I then use that mental image of my experience of treating it open, and I reconstruct that with the minimally invasive thing. All right, good, good. We're right in a good spot there. Shot. But we were. Then I moved it somehow. Let's see. Now? That's perfect right there, that exact spot. You guys see to the side of the circle, right where the transverse process superior border is? So, this will be our second burn out of 3. This will be the L5 transverse process burn. It's going to be the medial branch of the dorsal ramus. That's the name of the nerve if you want to look it up. Medial branch of the dorsal ramus. That's too high. Shot. It's still too high. That feels a little better. That's perfect. Medial branch of the dorsal ramus. And I'm dancing along the transverse process. Superior border right now. That's it. We got one more burn to go. Show them where I'm dancing. This is the key to the treatment. You got to dance right in this area, side to side, and then kind of top to bottom a little bit. Yep. So circle the whole area I'm dancing. I'm dancing in that whole area, okay? When doctors do a radio frequency ablation, they don't dance. They just leave it. And they put the needle in one spot and pray to God that it works. Well, or pray to God that it doesn't work, or that it works at least temporarily. Shot. Oh, look at that. That's the perfect spot. Show us the perfect spot. I just did. But the perfect spot is this valley between the superior articular process. Go up the superior articular process. No, that's the other way. There it is. That's the S1 superior articular process. You want to be in the valley between that and then the sacral wing going up. And that's the perfect spot. So that's where the nerve lives, the pain nerve lives, and we're going in to kill it. Basically, we're sending in our ninja assassin. And our ninja assassin was developed at Deuk Spine. Let's see if we can get it. Shot. Too high, too lateral. Shot. Oh, really close. There, let's see. Shot. Too low, I think. Yeah, a little bit too low. I can feel the sacrum here. That's what I want, is to feel it. You have a question there? That's perfect. You guys see that? I'm going to do my little dance. And this is where the pain nerve lives. Now notice how we're using the x-ray to find it, right? I can't tell you how important it is to have a good x-ray machine. You got to have a really good, top quality equipment to give patients the very best, because let's be honest, the devil's in the details, right? Especially in spine surgery. Everything's about small little things in small little places. You got to get it just right. Great job, everyone. 1 down, 2 more to go. Type up your questions. We're finished. That procedure you just saw, the Deuk plasma rhizotomy, is to cure facet joint pain. Not many people have it. About 10% of chronic back pain is facet joint pain. We don't have an exact number yet. We're working on that. But let's just say roughly 10% is facet joint pain. And you just watch the newest and most advanced permanent treatment to get rid of facet joint pain. Type your questions up. I'll be happy to answer them for you. If you know somebody who wants a free MRI review of their spine, we offer that. It's called the MRI. What is it called? MRI.DeukSpine.com, I think is the link. We'll type it up in the dialog box. You guys can click on it. It's going to ask you some questions on our webpage. You need to fill it out and send us your MRI, the images. And then I can meet you face-to-face on Zoom, and I'll show you what's wrong in your spine, what needs to be done to fix it, and answer any questions you have. go ahead and type up your questions for me. I'll come answer them for you face to face in the next few minutes. Let's show you one of our patients who had this procedure done. Hello, I'm Dr. Arjig Majan at the Deuk Spine Institute, and I'm here with one of my patients who's just came in for a checkup today, and she had the Deuk plasma rhizotomy. This is a new type of rhizotomy being done to treat facet joint pain. I say it a lot, but the most common cause of back pain and neck pain is a herniated disc. The second most common cause is a arthritic facet joint that's painful. And the standard treatment these days is something called a radiofrequency ablation, or RFA rhizotomy. The problem is that RFA rhizotomies don't deliver very much energy to the facet joint. So if they get the nerve, usually it's temporary and the nerve just grows back. We figured out a way to deliver more energy through what's called a plasma rhizotomy. It's a Deuk plasma rhizotomy, and you had it done about a week ago. Hello, I'm Dr. Arjig Majan at the Deuk Spine Institute, and I'm here with one of my patients who's just came in for a checkup today, and she had the Deuk plasma rhizotomy. This is a new type of rhizotomy being done to treat facet joint pain. I say it a lot, but the most common cause of back pain and neck pain is a herniated disc. The second most common cause is a arthritic facet joint that's painful. And the standard treatment these days is something called a radiofrequency ablation, or RFA rhizotomy. The problem is that RFA rhizotomies don't deliver very much energy to the facet joint. So if they get the nerve, usually it's temporary and the nerve just grows back. We figured out a way to deliver more energy through what's called a plasma rhizotomy. It's a Deuk plasma rhizotomy, and you had it done about a week ago. How do you feel today?
Amazing.
Yeah?
I have zero pain. So
And what did you say to me earlier? This is the first time you've been pain-free in
years.
years. How many years have you been dealing with back pain?
Yeah, probably 10.
10 years.
It's been a long time.
And you look very happy.
I'm very happy.
Now, you did have the RFA. It worked for, gave you some relief for a little while, then the pain came back. And this feels different though.
This feels different, as in within 2 days I had zero pain.
It's awesome.
And now here I am a week later. I can run a marathon, I think.
Good.
I
Well,
mean,
we want
I
you
won't
to.
yet, but I can, so.
All right, and there's millions of people out there, and that's why we do these testimonials, really for them, not for me, not for you, but it's to spread the message of hope that there is a way to get out of back pain. You just have to stick with it, find the right place, get the right procedure, and eventually you can get there. And what do you say to that?
I say you're correct. That's Deuk Spine Institute didn't give up on me. I've had several procedures, but you kept pursuing my pain until you figured it out. So thank you very much.
You're welcome. My pleasure. Anything else you want to say to your fans out there?
To my fans, come see this man. He is amazing. Deuk Spine Institute staff is amazing. Everyone treats you with respect, and they listen to you. That's very important to me. So I just want to encourage people, don't live with the pain. Please come see Dr. Deuk and Dr. Patel at the Deuk Spine Institute.
I appreciate you saying that. The lesson here is don't give up on your pain.
Yes.
There is a way to fix it. And a lot of patients, probably about 25%, end up having more than one source of back pain. And we have to treat each source because each source requires a slightly different treatment. The rhizotomies definitely were what you needed, but you needed a rhizotomy that worked well because of all the inflammation of the facet joints and the scar tissue. And the plasma rhizotomy is the most powerful rhizotomy that can be done. It's only done at Deuk Spine Institute. So congratulations on your new lease on your back. All right, let's get you out of here. And I'm Dr. R. Deuk Majan here at the Deuk Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Deuk laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing bang boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming, because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
All right, Dr. Patel has just joined me. How are you?
I'm good. How are you?
Good.
I have one patient with
So, thanks for joining us. We've just finished a challenging but I believe rewarding for the patient surgery. This patient had 4 discs damaged that were all 4 causing back pain. If we look here, at this spine model. This was not one of my patients, don't worry. Do a little spinal anatomy. This is the front of your spine right here. These are the vertebral bodies. Back of the spine, that's where your spinous process and lamina facets are. And this patient had 4 discs damaged. 1, 2, 3, 4. Starting right above the sacrum or tailbone, the L5-S1, the L4-5, L3-4, L2-3. And it was all on his left side. And we put a little hot tamale in there so you could see what a typical area of a herniation would be, where the tear would be, where the jelly would be coming out. And it's amazing because everybody else that does spine surgery, they all come this way down the middle. They have to take away your bones and ligaments in this area, peel your muscle off your spine, then they drill a hole in your facet joint just to get to the herniation here. They got to take part of your facet joint out. So they go this way. That's called a microdiscectomy, okay? Microdiscectomy. And that's the end result. But to do that, you have to remove bones, ligaments, muscles. Horrible, destructive surgery. Stay away from it. The Parvis Kambin, an Iranian orthopedic surgeon who taught many surgeons, including my mentors, a new technique coming from the side of the spine and not damaging anything, just passing through the muscles to get, bam, right there where the herniation is. Beautiful technique. It's called transforaminal. We do it endoscopically. This is the future of all spine surgery. Unfortunately, in the United States, 6,000 spine surgeons, only about 5 of us know how to do it. So we don't see it being picked up because the other ones are too busy putting metal in. They make a lot of money putting metal, far more than I make doing endoscopic surgery. So I don't see a financial incentive for these surgeons or companies or hospitals to change from this to this. It's going to have to come from patients. So we got a big hill to climb, don't we? Anyway, we went in and fixed 4 discs, 1, 2, 3, 4, all with one tiny little cut on his back. I just came out and redirected through the same hole to 4 discs, okay? The toughest one being L5-S1, passing through that little space. Everything went perfect, and then at the end, we ended up burning the pain nerve, which lives right there. And I'll show you, well, actually you can see it here. You can see where the nerve comes out of the foramen. So we went in and just deadened that nerve in 3 spots to treat his facet joint pain. Everything went perfect. We literally lost 3 drops of blood, 3. There was no blood loss and no damage to anything in his body. He will not need narcotic painkillers. 4 discs fixed, no narcotic painkillers. He will take a Tylenol and a muscle relaxer, and that's it. So, we're very excited. I think he's going to do fantastic. He'll be going home in about 45 minutes from now. 45 minutes home. This is outpatient. Back to normal activities tomorrow with some restrictions. All right, let's take our first question.
First question comes from Moises on YouTube, and they ask, how many days would I need to stay in Florida for this procedure coming from Texas?
Hello, Moises. Most people fly in. I'm just going to give you, let's pretend your surgery is on a Tuesday, because we only do surgery really Tuesday, Thursday. Sometimes we'll sneak in a Wednesday case or a Friday case if we're really busy. But right now our main surgery days are Tuesday, Thursday. Let's just say your surgery is Tuesday, okay? You'd fly in from Texas on Sunday night. You fly to Orlando. You could also fly into Melbourne, but I think Orlando may be the best option. I just came from Houston, Texas this weekend. My son was racing there. Was not a good weekend for us, but the flight literally took 1 hour and 45 minutes from Houston to Orlando. Once you arrive in Orlando, you'll get a rental car and drive 45 minutes from the airport. We're just east by the coast, and you come to the hotel just down the street. We'll give you that information. And then Monday, you'll be in clinic all day. I'll be examining you, talking to you. We'll fill out paperwork, history, physical, blood work, clearance, all the usual stuff. Tuesday would be surgery, like you see today. And then you go back to your hotel after your surgery. Come in for a quick checkup on Wednesday morning. It takes maybe 20-30 minutes, quick checkup. We just basically peel off your bandage, look at your incision, and then you tell us what a great job we did, hopefully, and then you get to fly back to Texas Wednesday afternoon. So I know it's a long, convoluted answer, but it's basically 3 days is all you need here in Florida. Now, some people choose to spend an extra few days because they enjoy Florida. They want to walk along the beach, check out the shuttle or the SpaceX program. We're right 10 minutes away from it. So really depends on you, but the bare minimum is 3 days.
Next question comes from Jordan, once more on YouTube. And they ask, do you find that L5-S1 pain is generally localized primarily to the back, or do you find that a large majority of your patients also have sciatica? Does it depend on how big the herniation is?
Great questions, Jordan. You're doing really well today on the questions. They're very informative for our other viewers. So you're asking about L5-S1. You're asking me, what do you find the patient's symptoms to be when you have a problem at L5-S1? Listen, Jordan, you got to understand, there's so much misinformation, false information out there that is polluting people's heads when it comes to back and leg pain or back pain. You don't need leg pain to get your back pain fixed. A lot of people are being told by their doctor, if you don't have any leg pain or weakness in your leg, numbness in your leg from a pinched nerve, you don't need surgery. It is not true. You don't need a microdiscectomy surgery or a laminectomy surgery. But the reality of it is that you do need surgery, but not for the reasons they're thinking of, but for the reasons of getting rid of your back pain, not your leg symptoms. So there are people with back pain and there are people with back pain and leg symptoms. The leg symptoms are known as sciatica if it's pain, or radiculopathy is a more general term meaning dysfunction of the nerve. You want me to eat in front of everybody? No, do not throw that burrito at me. All right, come on. Let's see how good my hands are. I know I couldn't be a football player. Oh, that is a monster burrito. Our sponsor today is Chipotle.
No free advertising.
No free advertising. So anyway, getting back to your question. So many people are told by their doctors, if you don't have leg symptoms, you just need to go to pain management, do therapy, do massage, live with it, take pills, smoke marijuana, whatever, right? All the bad things that don't work. And there's a lot of them. But your back pain is coming from that tear, and I can go in and fix it in 30 minutes and make you a believer like all these other testimonial patients you see. They were just like you. They're just like everybody out there. The people that you see in our testimonials, they were skeptical. They'll tell you, a lot of them will tell you, I was skeptical. I couldn't believe it. It's a miracle. Why do you think they're saying it's a miracle? They're saying it's a miracle because they didn't believe that I could fix their pain. But they still took a chance. They had some faith. You know, when you have faith and you trust and you believe, it doesn't mean you're 100% sure. It means you're taking some chance. And they took the chance and they have no pain. The reason they have no pain is because I know what I'm doing. The procedure actually gets rid of back pain. So you don't have to have leg pain. I would say at L5-S1, that's a good question for Arias, who's the head of our research. But he was asking how many people with an L5-S1 annular tear and back pain actually have no leg pain. I would say maybe 20% have no leg symptoms. Probably 80% of them have leg symptoms along with their back pain. Yeah, radiculopathy along with their back pain. So probably 80% have radiculopathy and back pain. 20% just have the back pain, no radiculopathy.
Next question comes.
It's my best guess.
Next question comes from Carlos on YouTube asking, for foraminal stenosis, do you use the laser to remove bone, or what is the procedure? Thank you.
Hey Carlos, on YouTube, great question. All right, let me show you what's going on. So take a look at this spine model right here. This area right here is the foramen. That hole where the nerve comes out is the foramen. Foramen means basically a hole. So the foramen is where the nerve's coming out. Okay, that's a normal foramen. There's no real stenosis there. And stenosis means narrowing, for those of you who don't know. Now, look at this side. Look at that. The foramen is narrow. It's stenotic. What's causing the stenosis? The herniated disc. And yes, this surgery you just watched is perfect for fixing foraminal stenosis because I'm coming in to the foramen from the side and I can remove the herniation. Foraminal stenosis is not caused by bone spurs. Lots of doctors will tell you that, but it's not true. Yes, there are bone spurs involved in foraminal stenosis, but they're not the ones causing the symptoms you're having. Bone spurs are everywhere, and they don't cause symptoms. Okay, 99% of people with bone spurs have no symptoms at all. What's causing your symptoms is the herniated disc, and that's what we can remove foraminally with the laser surgery you just watched. Great question.
Next one comes from Darren on Facebook, asking, does popping your own back, does popping your own back unhealthy?
Is popping your own back unhealthy? It's like popping your knuckles. So what you're actually popping, just so you know, are your facet joints. Your discs don't pop, your facets pop. See the facets moving? They pop. And what's happening is you got little irregularities on the surface. Normally they glide and slide normal, but when you injure your facet joint, you get these ridges, and what you're doing is popping over the ridges. You're popping them. Is it unhealthy? I wouldn't do it. Could it cause some facet pain later on? Probably. I would think it would. But I don't think it's like horrible for you. It's not like drinking paint thinner, but I wouldn't do it. I don't think it's that big of a deal if you pop it once in a while. Some people feel better when they pop their backs. If that's the case, do it. Ultimately you might have to have a procedure done for it, but if it makes you feel better now, go for it.
Next question comes from Carlos, once more on YouTube, asking, have you had patients coming from Mexico? If so, what is the patient's experience with them in regards of insurance? Thank you.
Hi, Carlos. Yeah, we have patients from all over the world. We've had patients from Mexico, South America, all the islands in the Caribbean. They all come here because they want this laser surgery done. They recognize the value of the surgery. We will take Mexican patients. We love Mexican food, and we like Mexican patients a lot. So I don't know what your insurance situation is, but you would have to talk to my scheduling team and get those details. My advice to you, though, Carlos, would first submit your MRI and do an MRI review. It's free. You're going to get 10 minutes with me on Zoom. You can ask me all the questions you want. If it's related to insurance, I'll try to answer them, but my team will answer them for you. My advice is get your MRI uploaded and let's do a Zoom. I'll show you what's wrong with your back. We'll figure out exactly what needs to be done to fix you. That's really what the Zoom call is for us, is to identify which discs need fixing and which side, left, right, both sides. So once I know which discs and which sides, we give you a price, because the more discs or the more sides is going to be higher price. So we can't tell you the price until we've done our Zoom call. Okay?
Next question comes from Moises. Is kind of the same thing. In relation, will Medicaid cover this, or what insurance cover this, or payment?
Hey, Moises, Medicaid will not cover the Deuk laser disc repair. 100% guarantee it will not. Now, maybe 5 years from now it will, but today it will not. As far as what about financing and cost, like I said, do yourself a favor. We don't discriminate against you because you have Medicaid. Just submit your MRI. Let's do a quick Zoom. I'll tell you what's wrong, and then we'll give you pricing. You can figure out if it's right for you or not. Okay? Definitely, the surgery's right. It may not. The price may not be right, but we'll give you the best deal we can.
That is it for your questions.
Okay, sounds like we're done. I hope you enjoyed the surgery. Our next surgery coming up is almost the same. We're doing 3 discs on the left, and then we're doing 1 disc on the right. So this next patient has herniated discs on the left at L2-3, 3-4, 4-5, and on the right at 5-1. And he has foraminal stenosis. He has bad foraminal stenosis, so bad that he cannot deal with the pain in his left leg. It's driving him mad. He's constantly having to pull his knee up to his chest and constantly having to wiggle his leg. He cannot deal with it. He's in so much discomfort from that pinched nerve from foraminal stenosis. We're going to go fix that today. We'll be back in about 30 minutes.